The money space is in the metastatic hormone sensitive, or perhaps even in biochemical recurrence. I think as we define molecular subsets and we find drugs like PARP inhibitors in DNA repair deficiency that have a big impact, that impact will likely be amplified when we move the treatment earlier in the disease, which is what we've seen with Charted for Docetaxel and Stampede for Docetaxel and Abby and Latitude, right? The earlier we use these drugs, the better. So I think that's the big space to focus on in trying to get patients even more durable remissions, provided we don't do it at the cost of quality of life. And a lot of the newer studies do incorporate patient-reported outcomes, which is really important since this is a longer-term disease process. We want men to live well as they're living longer. The other space that's open for revolution is really immunotherapy. It's been so disappointing that the immune checkpoint inhibitors haven't been as successful in these patients. We have our Sipuleucel T that's been around a while. We know men live longer when they get it, but we're really looking for something that's going to be a game-changing immunotherapy. There are many studies combining radiation with immunotherapy with immunotherapy, exploring which hormone therapies are most immunogenic, and I think it'll take a little bit longer for that to make its way into a great new clinical treatment, but it's definitely on the horizon within the next 5 years.